I would like to thank Novartis because of this unlimited support for the first meeting and future meetings also. And I will speak short for a very hot topic, which may be of a lot of concern for many of you, which is the RAS blockade in diabetic hypertensive patients. A lot of us and our neighbors, our colleagues are hypertensive diabetic patients. So what is the role of RAS inhibition in those patients? The agenda that we will speak about the burden of high-risk hypertensive patients, what is the link between diabetes and hypertension, and blood pressure goal for diabetic patients with hypertension, the guideline recommendations for those types of patients, and that interference with the RAS system protect against diabetes, and finally the valsartan calcium channel blocker amlodipine combination in a single pill combination and achieving blood pressure goal. The burden of high-risk hypertensive patients. We have hypertension as a major health risk in patients with diabetes. A lot of patients with diabetes have hypertension, and between 60 to 80 patients with diabetes will die of cardiovascular disease, particularly stroke. So stroke is very important in such patients. And many deaths occur without prior warning of heart disease, and myocardial infarction can occur suddenly without typical symptoms, and up to 75% of cardiovascular disease is caused by hypertension. Also, metabolic syndrome is very linked to hypertension and developing type 2 diabetes. Patients with metabolic syndrome are at high increased risk of cardiovascular risk, and it's a very common and widespread in Egypt, in USA, and in many countries, the metabolic syndrome. New onset diabetes is a very important term now. So you can prevent diabetes. Yes, you can. So you can prevent diabetes in patients or delay the onset or make it less progressive. And if you see here in this graph, the Kaplan-Meier analysis, the patients who have diabetes, they have the highest first event mortality and myocardial infarction and heart failure. New onset diabetes is also in between. The green one, which is never had diabetes, is the least to have a cardiovascular risk of myocardial infarction or heart failure. What is the link between diabetes and hypertension is insulin resistance. So insulin resistance is the key word. So insulin resistance is linked to a range of cardiovascular factors. There is insulin resistance in diabetes that makes hyperglycemia, dyslipidemia, hypertension, damage to the blood vessels, abnormal coagulation, inflammation, that all leads to atherosclerosis and the cardiovascular disease. The renin-angiotensin system is a main blamed person or a blamed object here in development of insulin resistance. And insulin resistance involves resistance to insulin-mediated vascular nitric oxide production and vasodilatation, and this could be antagonized by angiotensin II. If we block angiotensin II, so we can improve the insulin resistance. This is logic. How this occurs, angiotensin II works at the pancreas, going to the beta cells dysfunction, producing fibrosis, apoptosis to the muscles with impaired glucose transport, and adipocytes in the fat tissue, leading to a decrease the adiponectin and increased leptin and free fatty acids. In the liver, increase in the hepatic glucose output, and decrease in adiponectin, which is a protective thing. For the blood vessels, angiotensin lead to vasoconstriction, hypertrophy, and inflammation. For the kidney, it lead to increase the oxidative stress within the kidney. So if we block this main player, the angiotensin II, we have a lot of good things. And this is the goal that be achieved by the angiotensin receptor blockers and ACE inhibitors. And I will describe the difference between blockage of this and that after a few minutes. So what is the blood pressure goal for a diabetic hypertensive patient? The goal is controlled in the diabetes we have the UKPDS, which is the largest trial in United Kingdom as regard diabetes, and they controlled, or they studied the tight glycemic control versus the tight blood pressure control, and they found that tight blood pressure control is more important in diabetic patients to decrease the cardiovascular outcomes. So tight blood pressure control in yellow lead to 44% reduction in the stroke, while tight glycemic control leads to only 5% reduction of the stroke. And the same for any diabetic endpoint, deaths, microvascular and macrovascular complications. So according to the UKPDS, tight blood pressure control in a diabetic patient is of utmost importance, and it should be achieved according to the target goals. The goal is, according to the European Society of Cardiology, is to be below 130/80. For the ADA, or the American Diabetes Association, they go a little bit higher, and I will tell you why. So benefits of blood pressure lowering in patients with diabetes in a 27 trial, this meta-analysis. So if your patient is diabetic and hypertensive, adequate blood pressure control to the target leads to 36% reduction in stroke, 27% reduction in total mortality, and 25% reduction in major cardiovascular events. So the diabetic patient usually die because of his hypertension, not because of his diabetes. His diabetes, of course, he's participating, but if he's an hypertensive diabetic and not controlled, he's really in a big mess. The goal is the goal. The goal is to go to the goal, and the goal, according to the European Society of Cardiology, to be below 140/90 for normal hypertensive patients. But if the patient is diabetic, it should be below 130/80. So any patient, don't accept any patient diabetic with a blood pressure higher than 130/80, and this needs aggressive control of the blood pressure, which should be achieved mainly by angiotensin receptor blockers, namely valsartan. The American Diabetes Association in 2013 recommend that the blood pressure should be not less than the systolic 140. It's not a major difference, but they saw that 140 and 130, if the patient goes down to 130, the systolic blood pressure, no more benefit will occur. So keep him, according to the Europeans, below 138. So if you are in Paris or London, keep your diabetic patient below 138. If you are in San Francisco or in Chicago, make him 140, no problem. The guidelines, recommendations of antihypertensive agents for diabetic patients. The angiotensin receptor blockers act on the receptors of the angiotensin, and it's very important in diabetic nephropathy and metabolic syndrome. And the GNC7, which is the European recommendations for calcium and channel blockers in diabetic patients, it's very useful. So the ARBs is very useful, and the calcium and channel blockers are very useful for the diabetics, and it's a very good occasion to put them together. So if you put them together, you get the all benefit together. And this is the nice guidelines. The British one for 2011 recommend that if your patient is below 55 years, start immediately with ARB or ACE inhibitors. If he is above 55 or black person, start with calcium channel blocker. If he is controlled, okay. If not, combine both. So you will start either by valsartan or to shift to valsartan plus amlodipine. If valsartan amlodipine is not effective, so you will shift to valsartan amlodipine hydrochlorothiazide, namely Tarig, exforge, and exforge HCCT, which is the landmark treatment in the world of hypertension now in Egypt and in the world. So does interference with RAS system protect against diabetes? Yes. A lot of trials about the ACE inhibitors found that there is a significant reduction in the new onset diabetes with the use of ACE, but with the ARBs or angiotensin receptor blockers, a lot of evidence here also with cumulative evidence of delay of new onset diabetes. So if you are hypertensive and you have a metabolic syndrome or impaired glucose tolerance, take valsartan in order to prevent the diabetes, which was a dream to prevent a disease. Now you can prevent a disease by just blocking the angiotensin II effects on the beta cells of the pancreas. The problem between the ACE inhibitors and ARBs. The ACE inhibitors acts on the level of the enzyme, namely the ACE enzyme. So there is some leakage here occurs with a lot of angiotensin II that accumulate in the backyard from the back doors bypassing the ACE enzyme. But the use of ARBs, you block immediately the receptors, the AT1 receptor. So whatever you have angiotensin, the receptor is blocked and no effect on the receptors. What are the receptors? AT1 and AT2. AT1 is the blocked one, which is the harmful one, doing vasoconstriction, salt and water retention, stimulation of the nervous system and inflammation. AT2 is the good one, vasodilatation and natriuresis and tissue regeneration. So what the valsartan do is to block this bad AT1 and upregulate or enhance the AT2 receptor, so you gain the good things from the angiotensin receptors, and you are away from the bad effects of angiotensin on the angiotensin II-1. By time, with use of ACE inhibitors, there is leakage of angiotensin II, as I said, escape, and the plasma angiotensin II will increase with the chronic use of ACE inhibitors, leading to all these bad forms of angiotensin II. ARBs are the best in reducing new onset of diabetes with all trials, along the whole spectrum of the drugs that control blood pressure. Angiotensin receptor blockers, namely valsartan, is the main drug that could inhibit or delay the new onset of diabetes. But you should remember that not all ARBs are the same. So ARBs not the same. Valsartan is 3 times more selective for the AT1 bad receptors, harmful, than other ARBs. So it's great selectivity to the receptor. It's crème de la crème. And mortality morbidity endpoints with the valsartan from value, variant, navigator, Q to valheft, all these trials with the use of the drug, the valsartan, makes a very fruitful mortality and morbidity endpoints in major landmark trials. For some competitors, such as the olmesartan, when he tried to make a delay or prevention in type 2 diabetes like valsartan, he failed, unfortunately. And the conclusion in New England Journal of Medicine that the drug is associated with a delayed onset microalbuminuria and diabetes, but the high rate of fatal cardiovascular events with olmesartan. And that's why I said to you, not all ARBs are the same. So please decline this drug. Valsartan is the only RAS blocker approved in 5 indications from the FDA in hypertension, de novo hypertension, heart failure, post-myocardial infarction, heart failure with impaired glucose tolerance, and hypertensive children. Valsartan, amlodipine, and achieving blood pressure goal is the combination of synergy of both drugs, the ARB, which is the valsartan, and the calcium channel blocker, which is the amlodipine. Cumulative benefits of both drugs be in a single pill combination. This single pill combination is very effective in the compliance of the patient. So you will control all these things by just 1 pill in the morning, and that's all. So the patient go to his work, enjoy his life, going to his blood pressure goal with a single pill combination. So it's efficient drug, as shown in excellent trial with 49% reduction in 49 millimeter mercury reduction in systolic blood pressure and about 19 diastolic blood pressure reduction. The combination amlodipine valsartan in a single pill combination trial showed us that it's an incremental effect in efficacy and safety with a dose-dependent blood pressure reduction. So the higher the dose, you achieve greater blood pressure reduction and less bad outcome in the follow-ups. And this blood pressure reduction, according to the baseline, depends on the baseline. So whatever the baseline blood pressure, systolic and diastolic, the higher the blood pressure, the baseline, the higher is the benefit that got from the combination valsartan, amlodipine, exforge, the drug, the great drug. What about the blood pressure control? If you use exforge, you will achieve 9 out of 10 of your patients go to the target. So it's a miraculous drug. If you use a single pill, 10 patients, every 10 patients you succeed to treat 9 of them. It's marvelous. So it's protective. A lot of evidence, a lot of evidence about many indications, the value of the Valiant, the Valheft in heart failure, in renal patients, the DROP trial, how it reduces the urinary albumin excretion rate by the use of valsartan. Amlodipine also has a lot of wealth of cardiovascular outcome data in the PREVENT, Camelot, and All Hat, Ascot, Babla, Cafe. All these trials makes the combination perfect. So they are very good couple. They are the right couple. Finally, Romeo finds Juliet. What about the tolerability? It's a placebo-like. So no contraindications, less hypotension, less headache, less edema, and less angioedema. So it's the perfect pill for the perfect patient. Thank you very much. We enjoyed you a lot today. Thank you for your coming and enjoy your dinner.